So the last talk is going to be on medical decision making. And I first gave this to some house staff about 3 months ago. And I'll tell you some important points on medical decision making, because really what we do for a living, you need to do two things. You need to know what standard of care is. So you need to know, for example, the ACEP guidelines. The second thing, you've got to take the right critical actions. Like saying you need to offer TPA, or you need to go to the cath lab when you recognize a STEMI, right? Those are critical actions. You need to give TPA or neurointervention for stroke patients. So we'll make this, you guys have to go to lunch in 20 minutes, we'll get there. Doing okay so far? Again, every PowerPoint's in your handout. It's not my fault that Ken and Zach wouldn't give me more than an hour and a half, but that's good. So how do you make decisions? You need to know content. You need to know some life-saving procedures. And it's surprising how important your triage note is. Based on complaint, I'll give you some evidence on that, and based on vital signs. And there is something about clinical judgment. You can't admit everybody. Well, I don't think we'll have time for Tala today, but that's good because I hate talking about it. All right, so let's talk about one example of knowing content. And that is people at TIAs, which has now changed in the last 6 years. When the ACEP policy initially written in 2009 came out, it said that if you looked at ABCD squared score. Do you know what an ABC squared score is? It's, again, what you should do is I keep ER-Res in my pocket. You can go to ER-Res. I think it's free or costs $3. You need to get some decision tools on your smartphone or somewhere else. There are others than ER-Res, but I like ER-Res, and it has all the stuff in it. But what they did was they rewrote, when they looked at the data from the last 6 years, the people who did the TIA policy basically changed their mind. There are like 6 different decision tools. They basically said they weren't good enough. They weren't accurate enough. So basically anybody with a anterior circulation TIA, all right, so they had 65 minutes of left side weakness with some facial asymmetry, but it's all gone now. Those people need probably to come into a clinical decision unit or an OBS, because those people need probably an MRI. They need an echo. They need the image of neck. So they need MRA of head and neck, or MRI head plus ultrasound of the carotids plus an echo. And even if their ABCD squared score is low, they need to have all that stuff. Plus you probably want a neurologist to see them within 24 hours, because probably the incidence of stroke in the first week is 3–4%. So that changed from 2009. You really need to do, you need to image the carotids. Because if you have someone with the same presentation, but they have high-grade stenosis, you need to come in. So I'll give you a couple of my comments because it's all in blue. But it's clinically confusing. And there are stroke mimics that sometimes you get fooled with that. But the fact that stroke incidence is anywhere from 3.5% to 10% at 2 days, with too many sources to list, you don't want to send these people home and have them stroke. Then they call those ugly Elk brothers up, and then you're in deposition for 5 years. And stroke litigation is common with large payouts. And it is a problem because grandpa has these symptoms for an hour, now they're resolved. It's 8 o'clock at night. He doesn't want to stay in the hospital, right? So you got to sort of talk to him about it. And plus, payers don't want to pay for it. But the contention is, vis-a-vis ACEP, that you really need at least if they're, I would say this, if they're in sinus rhythm, if you get a carotid ultrasound which shows no high-grade stenosis, and they have no symptoms, and they want to go home, if you do all that and document that and talk to their PCP and see them the next day, you're probably okay. And they're probably okay. All right? But at least you got to image the neck and make sure they're in sinus rhythm. If they're in AFib, that's a higher risk patient. All right? So you need to know the content. And really CT, the only value of CT is to rule out tumors and bleeds. And it's hard to get MRIs. And per those policies, the death of the ABCD squared score and 6 other prediction rules. So the TIA workup is made for the ED managed CDU, clinical decision unit, because you need all this stuff. But every hospital has a OBS unit now. Or every hospital has people on call, usually internists. So as long as they know that they have a neurologist to consult, they'll take the patient. Probably don't want to send them home, though. So that's content. You need to know life-saving skills in medical decision-making and being a mid-level ER doc. You don't need to know every skill, though, but for airway, I think Zach, do we have the A-scope people coming today? Yeah, we do. A-scope's outstanding. So the A-scope, I wish I would have learned it 30 years ago. Okay, they didn't have it 30 years ago, but it's an innovating bronchoscope that ER folks can get pretty good at. So you'll get a chance to try that today. All right, because sometimes people, if you've got angioedema, other upper airway obstruction, you really can't lay them down, and you really can't see much with even a glide scope. So that's really a good opportunity to, and we're going to have the A-scope probably at every one of our facilities eventually. So you need airway, okay? So glide scopes, A-scopes, you know how to put a chest tube in, you need to get venous access, including intraosseous line. You don't have to have a vein, but you have to have at least know how to get venous access or easy IO, and you know how to stop bleeding. So this is a real case we had about 4 months ago at Ahuja. What do you think this case was? Have any idea? It was an ACE inhibitor angioedema. And we had a really good doctor working, Dr. Goldstein, and she had an A-scope. She had a catabant, which is an ACE inhibitor reversal agent, but it takes 2 hours. And the patient still looked like this. And luckily, it's a true story, it was a Sunday night, and there was an anesthesiologist on call who just happened to be driving by the hospital. And Jessica said that he came in, he basically said, let me take a look. He saw a little sliver of the epiglottis and Brown got a tube in. At the same time, they were prepping the neck for a crike. All right? But these cases are disasters, and just lucky for this patient. He did fine, by the way. This is the A-scope. You'll get a chance to use that today. Other things like retrograde wires. Everybody should know how to use an easy IO, because you get these 400-pound people who come in, they're cardiac arrest. So let's say they're PEA. If they're asystole, they're dead, right? But if they're PEA, they might not be dead. And everybody's looking for a vein. Just drill their tibia or their humerus and get going. Okay? Knows how to use easy IO. Tourniquets are back, by the way. They were out for 20 years. We have, if you have someone's insanguinating, don't worry about using a tourniquet, use it. We have tourniquets in all our ERs in the field. I won't go through all Ken's cartoons today. Now, you need to know about decision tools, okay? We're talking about medical decision making. So in my ER res are all my decision tools, because you need to risk stratify everything which you can risk stratify, all right? So you need to know how to risk stratify acute coronary syndrome, PE, DVT, syncope, pneumonia, sepsis, and maybe abdominal pain. So let's talk about a couple of those. I've got 12 minutes, I'm good. So actually, in our system, you probably want to use a heart score. And more impressive, this is a validated score. It's heart. Can you imagine this? It's not only is the score good, but it's history, EKG, age, risk factors, troponin. Whoever devised this was brilliant as far as the acronym. And the UH system uses this right now. So if you have someone who comes in with chest pain that might be ACS and their heart score is less than 4, you can send them home. Okay? If it's 4 or greater, you admit them. If it's 4 to 6, you put them you put them obs. If it's greater than 6, you call your cardiologist to maybe do something invasive for you. So know the heart score. It's in my pocket. You all have to know it. Okay? Wells score. For PE, it's either Wells score, Perc score, or Gestalt. So it's a grade A recommendation. If you have someone comes in with a possible PE who's low risk, you need to do a Wells score. Or you can Perc them out. If they're 0 out of 8 Perc, or a Wells score that's less than 2 with a negative D-dimer, you're done. If it's greater than 2, you got to work them up. All right? If the D-dimer is positive, you have to work them up. And I don't want to talk about age-adjusted D-dimers, but that's probably real. So if you have an 80-year-old who comes in, their normal D-dimer level is 800 rather than 500. All right? So you can talk to your, what I would do is if it's between 500, if it's 800, I'd still talk to my patient's family doc and let them go home. There's also something, I got a call the other day from another CMO down. It was pretty good. He called me. He goes, he had this guy who was a world-class athlete, who was hypercoagulable in his 40s, who was on a 10A inhibitor, I think it was on Eliquis, who now had multiple PE. He said, this guy doesn't want to stay in the hospital. What do you do? There's something called the PZ score. It's in my pocket. Pulmonary embolism severity index. Canadians send 50% of the PEs home using a validated score, the pulmonary embolism severity index. So even some PEs you can send home on a 10A inhibitor. So you can load them up with Xarelto, and you can send them home for follow-up. But you want to risk stratify even a known PE, although in our country, in our region, you probably keep these people overnight at least. All right? But there is a pulmonary embolism severity index. And this is Wells criteria. Again, keep it in your pocket. You have to memorize it. Geneva score for P, which no one uses, but it's there. Perc is great. So, you know, a 30-year-old female who's got a little bit of pruritic chest pain, no real URI history, but she looks absolutely fine. Her heart rate's 60. Her pressure's fine. She's not on birth control pills. She's not hypercoagulable. If there's 0 out of 8 Perc, you're probably done with them. You know, you don't have to scan these people. Here's the PZ score. Won't go into it today. Syncope. San Francisco is pretty good, but it's not really sensitive enough. But there is a San Francisco syncope rule. So you can send a lot of these people home. Basically, if they don't have any family history of sudden death, they have a normal EKG. What do you look for in an EKG in a person with syncope? What's that?
Prolonged QT.
That's 1.
Regatta.
That's 2. What?
Any arrhythmias.
So delta waves for Wolff Parkinson White. So you look for Brugada, which is usually ST elevation V1, V2. You look for QTC. And you look for delta waves, and that's good if they have a normal EKG. None of that stuff. They have no family history of sudden death. They have no structural heart disease. Their basic workup's negative. Usually you can boot them out, and that's echoed by the San Francisco score. No pun intended with echo. So I would know the San Francisco syncope rule. Curb 65 is one of the scoring systems for pneumonia, because a lot of people from pneumonia can send home. So you can use Curb 65 or you can use Port. So, you know, you have someone with pneumonia, syncope, possible PE, possibly ACS, you got to stratify them all. You just can't guess or put them all in the hospital, right? Your hospitals will hate you. Plus patients will hate you too. So you need to know how to risk stratify everybody. We talked about serious criteria for sepsis and Q-SOFA. Alvarado score is basically worthless, but I got to talk about this to the residents of case this month. And that's a scoring system for appendicitis, but it was only based on 300 patients. I think it's pretty worthless. So I won't get into it today. There's actually 4 scores now for appendicitis, and this showed that the Omen and Repassa score were better, but I won't talk about this today. So bottom line is risk stratify these high-risk complaints, document, and then base your decision on your history, physical, labs, imaging, medical follow-up, social support system, clinical judgment. All right? Anybody can admit somebody. It takes a lot more skill to send them home with good follow-up. Any comments? I got 8 minutes. We're going well here. We're doing well here. So we talked about that. Oh, yeah, okay. Great paper, okay? So I talked about the nurse note, triage note. This paper looked at a 20% sample of every Medicare patient who was seen in an ER over a 5-year period of time. And they found out a bunch of things, but the main thing they found out was this. There were only 3 chief complaints. They had likelihood ratios of more than 1 point. So 3 were greater than 3. And these were all close to 1. So the 3 high-risk complaints, what they did is they looked, everybody came back to an ER dead within a week. And they found 10,000 a year, believe it or not. It made the Elk brothers very happy when they read this study. It's not just you, though. It's you know, there are 10,000 a year. What it showed, here are your 3 high-risk complaints. Ultimental status, likelihood ratio more than 3. Dyspnea, likelihood ratio more than 3. May laser fatigue, likelihood ratio more than 3. All right? So those 3 complaints had a likelihood ratio of more than 3 for predicting death. So again, when you have that same little old lady who comes in with just feeling weak, don't blow it off. Real stuff. Great paper. 5 years, 20% of every Medicare patient sent home and came back dead. All right? Compelling paper. Another compelling paper. So that was history, right? 3 high-risk complaints. What David Scar's paper showed is there was one really high-risk finding. He looked at 10 years of discharge from the University of New Mexico ER that came back within a week, then who came back within a week dead, then came back within a week dead due to medical error, and he published it, which I thought was really gutsy. Now the 35 people who they found due to doctor's error, 29, I think, left the ER in sinus tachycardia. And I've talked to Dan Sullivan about this, who's a big risk management guy who agreed 100%. Sinus tachycardia is a sign of badness, right? And again, don't just attribute it to people's pain and anxiety. Again, check your pulse. You can never get your heart rate over 100, all right? So what can cause sinus tachycardia and kill people? Could be heart failure, could be blood loss, could be a pulmonary embolism, could be thyrotoxicosis, you know. So these are all high-risk things. So when you look at the nurse's note, if they have a chief complaint of dyspnea, weakness, or fatigue malaise, or they have an initial heart rate more than 100, you walk into that room knowing they're high risk, and you have to really show they're not high risk based on your history and physical. Make sense? You guys all owe me about $5 for that information. It's critically important information. Make it $10. All right. The 117 people reviewed, 58 were unexpected, returned to ER, and 35 had possible error. So what we did a few years ago is we did a 100-100 campaign, which meant that if I discharge a patient with a heart rate greater than 100 or systolic blood pressure less than 100, the nurse refused to discharge them. And what we found is we had a lot of people who you took a second look at. Because, you know, let's talk about reality here. you see grandma at 9 in the morning. Now everything's back and it's 1 in the afternoon. And you forgot that her heart rate was 115, right? You know, all labs are okay. CT, the head's okay. You know, everything came, chest x-ray is normal. Everything came back normal. And you're ready to go back and discharge grandma. And you forgot. So to have a nurse say, hey, Howard, do you realize that her heart rate on the chart's 115 and the repeater is 110? It's a big help. So really, we need to have this at every one of our places. And we're working on that right now. And that's about it. Clinical judgment, I'll just tell you, this is Malcolm Gladwell who wrote the book Blink. And if you haven't read Malcolm Gladwell, he's pretty good. And what Blink was, the book starts with a vignette from the Getty Museum in LA. And what they had is they were going to buy a painting for $2 million. And they were trying to determine if it was real or fake. And they went through like 12 months. They had different consultants came in, and 2 consultants told them it was real. And they paid $2 million. And then the next month, someone came in and in 10 seconds said that's a fake, and it was a fake. So yes, I think it has to do with clinical judgment too. I think some clinicians are better than others. It's sort of knowing what sick or not sick is. But if you know all the other stuff we talked about, I don't think it's that big of a deal. But you know, some people, frankly, are better than others at walking into a room and smelling something bad, as far as this patient might be sicker than you think. But if you're careful with their vital signs, their chief complaint, you risk stratify them, you do a good physical examination, you'll get better at knowing who's sick or not, and I don't think it's that big of a deal, to tell you the truth. And what I did for my long talk is I reviewed about 9 or 10 papers with really good investigators trying to determine what clinical judgment was. And the punchline was no one really can say much about it. Okay? So it's 12 o'clock. Did 4 talks, an hour and a half, pretty good. It's all in your handout, and if you have any questions, come and talk to me. I'll hang around for a few minutes. Thank you.